Welcome to this provider education session on documenting brain or cerebral pathology. We will cover 3 common documentation pitfalls and the precise codable terms you should use instead. The goal is simple. Turn what you see on imaging into a clear diagnosis in your assessment and plan. Let's start with the single most important idea in brain pathology documentation. A description is not a diagnosis. Imaging phrases like mass effect, midline shift, effacement, space-occupying lesion, or hydrocephalus describe what is seen, but they are not codable diagnoses. To get credit for your work, you must interpret the findings and document an actual diagnosis in your assessment and plan. Otherwise, you will get queried. The first pitfall is mistaking descriptions for diagnoses. Terms such as mass effect, midline shift, effacement, space-occupying lesion, and acute or chronic hydrocephalus are commonly used. But they are descriptions of the pathology observed, not diagnoses. They are not codable, and they will trigger a query. Interpret the findings and document the underlying diagnosis so your effort is captured. The second pitfall is not evaluating the diagnostic findings. Descriptions of pathology are invalid unless you, the provider, have evaluated the findings and documented the correlated diagnosis in your assessment and plan. Seeing the finding is not enough. You must connect it to a diagnosis and put that diagnosis in your note. The third pitfall is not confirming diagnoses noted in diagnostic reports. A diagnosis that appears in a radiology or other diagnostic report is not valid on its own. It needs provider acknowledgement. You must evaluate the proposed diagnosis and either acknowledge it or deny it in your documentation, or answer the CDI or coding query when one is sent. So what should you document instead? Here are 3 precise codable terms for brain pathology: cerebral edema, cerebral compression, and cerebral herniation. They sit along a spectrum, from swelling to pressure and displacement to herniation. Let's look at what each one means and what commonly causes it. Cerebral edema is swelling within the brain. Common causes include trauma, neoplasm, stroke, intracerebral hemorrhage, hypoxic brain injury, brain abscess, toxins, and extreme electrolyte abnormalities. When you see swelling, name it as cerebral edema and document the underlying cause. Cerebral compression is pressure on the brain that produces displacement, and it commonly, though not always, causes some degree of herniation. Causes include cerebral edema, traumatic brain injury, and intracranial mass such as a neoplasm, hemorrhage or hematoma, hydrocephalus, brain abscess, or a foreign object. Document compression when there is pressure and displacement. Cerebral herniation is displacement of part of the brain across or through a fixed intracranial structure, such as the falx, the tentorium, or the foramen magnum. It may occur when cerebral edema and/or compression becomes severe. This is the most serious point on the spectrum, so document it clearly when it is present. To recap, imaging descriptions like mass effect and midline shift are not diagnoses and are not codable. Evaluate the findings and document the correlated diagnosis in your assessment and plan. Acknowledge or deny the diagnoses proposed in diagnostic reports, or answer the query. And use precise, codable terms: cerebral edema, cerebral compression, and cerebral herniation. Interpreting the findings and naming the diagnosis is what gets you credit.